Welcome to Rewired, navigating AI's role in kidney health. This series will dive into challenges and triumphs as artificial intelligence continues to evolve in kidney care. Each episode will feature leaders in this new intersecting space.
Welcome to Rewired. I'm Karandeep Singh, a faculty member and Chief Health AI Officer at UC San Diego and member of ASN's Partnership for Responsible Augmented Intelligence in Kidney Health. I'm joined today by Dr. Amy Waterman.
Hi, I'm so happy to be here. I'm a professor and a director of patient engagement at Houston Methodist Hospital and the J.C. Walter Transplant Center. And I'm also a member of the ASN Partnership for Responsible Augmented Intelligence in Kidney Health.
ASN started this partnership as a strategic priority for the organization. This podcast series is intended to help the practicing nephrologists and the community understand why should they care about technology, specifically AI, in their day-to-day interactions with people who have kidney diseases. Today, we're going to talk about the role of AI in kidney transplant care. Amy, there's been a lot of attention on the eligibility in transplant and access to transplant care. For example, a lot of work has gone into understanding the role of estimating the glomerular filtration rate accurately to be able to get equitable eligibility for transplant. Not as much attention has really been given to looking at the entire patient journey, which starts well before they're thinking about needing to get a transplant and going through that conversation with their nephrologist. And in transplant, getting through the evaluation process to the point where we're actually on the wait list can be daunting. So from a patient perspective, in your view, what are some of the challenges that individuals face before they get to that kind of moment in their life where they actually receive that transplant?
Yeah, I think the piece that anyone who works in transplant learns quickly on the ground is that going through from signing up and calling to start transplant to actually move forward to get listed can be months to sometimes years. And in the course of that, what we see, and the data is showing, is that between 40 and 50% of people don't make it from the first call where they say, I would like to be considered for a transplant. And it's not because they're medically ineligible, it's that they faced all of these challenges. And it can be everything from being unaware of how many tests that have to be completed, having to wait over time to become healthy enough to be eligible for a transplant, facing financial challenges to go through this process, having families support them or not having a living donor on the ground that are trying to help people move forward and be successfully getting waitlisted and then hopefully getting a transplant.
So as a health services researcher and a director of patient engagement at a transplant center, you have a really unique view into this space because you think like a health services researcher and you understand healthcare delivery. And yet, I think when you saw this kind of problem on your plate in your lab, you saw the potential of AI. So my question for you, which some of our nephrologists and community may be thinking about, is as a health services researcher, how have you made this work? Were you familiar with AI when you got started with this work? And how has your knowledge in your lab evolved to be able to get to a point where you actually can tackle some of these problems?
Yeah, I think that I look at every new initiative that is happening as potentially a tool to help our patients, right? And to help our care delivery system move more swiftly and efficiently. And so in the case of transplant, when I saw AI coming out, I was like, okay, how is this going to make our understanding of the patients that are dropping out more clear? How can it target people that we most need to care for differently? How to, who are the people that are going to drop out? If we could know that earlier, maybe at the point where they called to start their evaluation, then we could activate interventions on the ground. Like maybe they need financial services sent to them. Maybe they need to move more in a fast track way through transplant. So the piece to me was, what is AI? And I really want to say for anyone who's listening, I did not understand at all what it was. So when we first started, we're 2 years into this. We've just put out our first paper on this through the American Society of Nephrology, but I have been learning how this could help my patients' experience be better. And I got excited, I think, because what I get is now I can look at my data of Epic and I can look at the characteristics of my patients, and we can actually have a risk prediction model embedded in Epic on day one to say this patient's going to need more support.
So earlier, I think on the podcast series, we've talked about the role of predictive AI and the role of generative AI. And, like my question, I guess, to you, just building on that last question is, there's really your work, and we'll get into some of it in a bit more detail, actually touches on both. So, what did you do to educate yourself to be able to actually do this? And what are some of the folks in your lab that actually make this work to be able to do both predictive AI and generative AI in your work?
Yeah, I think that it takes a village to do AI work in implementation. It takes people who understand how to build models and to use machine learning to determine characteristics that matter. But you also need to be interpreting what is happening through a clinical lens. And so I have a big team of nephrologists, of transplant individuals, of researchers. And then I actually have a community engagement arm where once we find a model that works and that the doctors are understanding how it works to help our patients, we bring the model to the patients that the risk models would say are going to drop out so that we can hear what would help. So it's what's interesting is it kind of, I've found in my own work that utilizing AI starts a series of dominoing actions that allow us to build interventions that are guided by really smart models, but then we listen to what the patients need and the clinical system allows, and all of that can run smoothly to reduce dropout.
Yeah, I think there's almost incorrect view that you have to be an expert in AI to get started with AI. And I think that you can be an expert in application. You can be an expert in discerning what the problem actually is and what people actually want you to do to help them on their journey. So I think that what you just shared, I think really exemplifies that doing AI work in this context of health system care delivery is not a one person job. It's really requires an entire team with complementary expertise, some of which includes AI, but actually that might almost be like the minority of the actual expertise that's needed in total to be able to deliver on that vision.
Yeah,
So
that's
let me
my
put
experience.
myself, oh, good.
Yeah. Oh,
So let me put
sorry.
myself in the shoes of a patient with advanced kidney disease. Okay. And I want to hone in on some of the specific predictive AI work that you've done. So if I'm in this situation and I'm still being seen by primary care, haven't been referred yet to a nephrologist, there's a long journey between where I am today in my care and where I will need to be to the point where I actually go ahead and receive that transplant. So when you looked at this journey, where did you feel like from a predictive AI lens or all the places where we can use AI to actually help identify the right people so that the people who need the intervention along that journey, of which there may be many different interventions, can actually get that?
So we know with transplant, it's a narrow group of people who are interested in transplant. But what we know is as you move backwards into the large population of CKD patients, where do we prioritize our efforts? How do we find people that we need to be intervening either to slow kidney damage from happening, period, or to also identify people who need to be referred into a transplant center? So a lot of the work we've been doing, and many other people have been doing as well, is we're looking for patients who are having rapid progression of CKD. And we found in the state of Texas, I'm working with a big consortium, but we found about 12% of the patients at Houston Methodist, for example, are are in high progression of kidney disease. So then the idea would be, all right, are they getting cardioprotective medications to slow their kidneys from functioning sorry, I'm gonna say it again. So of the 12% of all of our CKD patients that we're taking care of at Houston Methodist, what we want to say is, all right, first of all, are the patients seeing a nephrologist? Are they getting cardioprotective medications prescribed to them so that their kidney function can slow or even stop declining? And then finally, if they're at the point that they're in end-stage renal disease, are they getting referred for transplant outside? So it creates a continuum of care approach where we're looking at who do we need to focus on most urgently. And then after we know who they are, we can actually say it's Amy at her, at this doctor's office. And these are the recommendations that we have. And it looks like, based on what we can see in Epic and in our medication, sure scripts, that Amy needs these things to happen. And so the opportunity for our whole institution is that we can have people, we can literally be doing direct individual recommendations for the highest risk people. And what excites me, because I'm a patient engagement expert, is this idea that, wow, we can actually stop kidneys from failing, right? We know exactly where to target our money, our effort, our people, our interventions to say, these people, it's going fast. Let's focus on them.
So that's the upstream part of it. And I think that I love that you didn't start with people referred into nephrology. You actually went upstream, where I think a lot of the community sometimes forgets that there's actually the majority of people with some level of kidney disease aren't seeing a nephrologist. They're out in the community getting care from primary care. So when you then get to the point where you've now seen a nephrologist, okay, and now you have had that conversation, you are interested in pursuing your eligibility for transplant. What next are there some of the barriers? And like, what have you done in the predictive AI space to try to find those patients who have issues in actually completing that process of getting the transplant?
What I've been fascinated about using AI to try to understand our patient's progression from CKD to end-stage renal disease is how you can use the tools of AI to help you better plan what you're doing. So to give you an example, I found out that we can find not only the patients who are having rapid progression to kidney failure, we can also find in which zip codes they live and what kind of community-based challenges they might be facing. So there's a level of, yes, you can find that there's a person and their characteristics. You can also find clusters of where people are living and what challenges the people are living in that might affect them being able to take care of themselves. So it's so interesting to me, and everyone who's been coming to the larger consortium that I'm a part of is bringing a different lens on how this could improve care. So as I bring a group of people together that are experts in AI, experts in clinical work related to CKD, and then health services researchers, people are applying AI in different ways. There's one group of people that are looking at the social drivers of health, and they're trying to say, what is it about the environment that the people are living in that is affecting them not taking care of their health enough? And is there anything that we can do? Then you have people that are working in primary care offices and nephrologist offices that are figuring out how we can provide care outside of the doors of the transplant center more effectively and ensure referral. And then we're watching whether the referral is happening. So all of this whole process is leading us to detect areas of opportunity for significant interventions to be happening. The other piece that I'd say that I have had the most fun doing is we can say that a patient didn't make it forward. They didn't go from a primary care to a nephrology referral, right? What to get to talk to the patient with those characteristics and for them to say, I did not even understand that I had CKD. I knew I had diabetes and hypertension, but I didn't know I had CKD. Or I don't understand the value of cardiometabolic medications for preventing my kidneys from being damaged. As we discover where our patients aren't with us, then we can embed that at these key critical points.
And then there's also a similar process that happens among living donors. I think that there's people who need transplant and there's people who are considering donating their own kidney. How do you think about that side of it? That's like almost the other half of the donation process.
Yes. So what we know is we get at our center, we have over 1,000 people who are potential living donors. And then by the end, we have 150 people who actually donate generally. So same pattern, if you really think about it, right? You have the interested people, you lose people who choose not to respond to calls after a while. And we say that they have opted out by not communicating with us. What happened there? In the past, we just say we didn't call them. We can now use AI and machine learning to understand various characteristics of people who are more likely to drop out. We can say this person at time 0 is a higher risk of dropping out. We then can literally be planning different interventions. And that's more in my camp because I live in the transplant center. And what's so interesting is all of the types of interventions that have been proposed, we can tailor. And so we have people who need to lose weight. We have people who are scared of the financial costs, right, of being a donor. We have people who weren't prepared well coming in, and then they quit on us. So you can see what factors to find out about at the beginning and then intervene as we move through. So I think where I geek out is that I'm like, wow, we can individually tailor care. We can identify where exactly to tailor care. And then we can focus our efforts on the patients and the donors, the potential donors who most would benefit. And that's going to help all of us.
Yeah, I think one thing that you is really interesting about your work is that when we think about using predictive AI, we often think about doing interventions or doing shared decision making at the individual level. And certainly, I think in the case of the medication adherence work that you're doing way upstream to try to get people on the right cardioprotective medications falls into that kind of camp. But then with the predicting dropout work with patients and living donors, you're actually also not just using this socioeconomic status and kind of social drivers of health as predictors, you're also looking at that angle from an intervention lens of what can we do in areas and zip codes that actually have these problems that we need to fix at the community angle. And I think that's a really important thing for our community to hear is that it's not just building that model and then using it to tell the patient, hey, look, tough luck. You have a low risk of making it through. That's not a very appetizing thing. And I think the folks who are skeptical and maybe cynical about the use of AI in this way have pointed out there's lots of places where AI can tell you the risk, and yet you actually can't do anything to fix it. And I think that your work exemplifies that things we think of as maybe cynically non-modifiable factors like where you live might be things that you actually can intervene on by figuring out what is it in those communities that is the gap that's accounting for or causing that disparity to happen, and then to directly try to address that gap out in those communities. So I love that, and I think that's maybe an interesting takeaway. You also have done
Yeah.
work, I think, in the generative AI space with chatbots and looking at the role of technology, not only to identify the people where there's a problem, but potentially also as part of the actual solution and part of the intervention. So, can you talk about the role of tech and AI as possible ways to intervene on patients where they actually are at high risk?
So I always think with when you're thinking about patient education, so if it's a website or a brochure, or we had somebody call a 1-800 number, but we also know that people have to be able to read. They have to be, the information takes a long time to develop because it has to be health literate. It has to be in multiple languages. There's some patients that need a phone number to call because they're not going to read it all. And we all spend a lot of money and a lot of time building that. We're now in a world, our new world here, we can build so much education that can be health literate and in multiple languages very quickly. We can also build things like chatbots where we can have patients query and have the educational answer or response directly to their particular question emerge for them, which is a patient guided educational opportunity versus that we just give them a large binder. And so, what is exciting now for me is how do we use this tool? But I also want to say something else. The tool alone, saying, here's a chatbot, go to it, you can trust it. I think we're all concerned that might not be the way to go. And I think our ASN committee has really said, how do we connect the tools of AI with clinician support and not break that up? And so, my passion is to both build tools using efficiencies of AI and design of education and answering questions and all that, but then have a handoff for the person who wants to talk to a human partner, or a handoff to a social worker because they're having a large amount of anxiety, or a handoff to a doctor because this is now something that should not be handled by an AI tool. So my belief as a patient engagement person is that there's a lot of work we all need to do to say, when can the tools be provided and they actually increase efficiencies? And when should we come in and be there for the critical points that only a clinician and an educator and a human being need to be there? And so it's an exciting and also a little scary space. And I think it's going to take the leadership of nephrologists and our care teams to navigate this.
Yeah, this reminds me of this editorial in the New England Journal of Medicine by Dr. Zach Kahani called Compared with What, which is that when we're thinking about dropping in an AI tool or an AI-based technology where it's going to do maybe some digital handholding, people often look at that and think, well, wouldn't it be better if a clinician did that or if a trained person did that? And I think the reality is that the current standard of care for many of these things where we want to have these kinds of digital handholding technologies is nothing. And so I think that when we compare against kind of what can we deliver today, it's often not is digital better than people. It's actually, is digital better than nothing, especially if we can use digital as an entry point into getting connected with the right people so that we can minimize the kind of people places where there's not as much value, or where you're just saying, oh, you actually need to talk to this other person because you were incorrectly referred to me. This kind of makes sure that people get the right care at the right time. And I think actually frees people up to be able to focus more of their time and effort to doing the handholding where it matters, to let digital handholding be a supplement to that.
I just really want to celebrate what you just said. So let me just say that cleanly so you can link it. I really want to underline and celebrate what you just said, because as a person who is part of the care team and an expert in patient engagement, what I know is the moment with the doctor is not enough. Sometimes my healthcare partners say, well, I have 5 minutes to do education on this, or I'm managing and juggling. So what I see here is we have a system where there's high degrees of provider burnout. We have not enough providers, and we have increasing numbers of patients joining our team. So if we can use these tools and build them to be partnering well with our busy and important nephrologists, then I think we're going to improve the patient experience, period.
So that's great. So the question I want to ask is the question that I think our community members not sitting at Houston Methodist are going to be asking, which is, so I'm a nephrologist out in California, or I am a patient out somewhere else. What is it going to take some of the work that you've done in kind of a really rigorous way or have undergoing, and get that to the point where it's actually part of a clinical guideline? It's part of just the way that care is delivered. What do you feel like needs to get tackled next? I know there's a lot that would have to get tackled, but what do you feel is like the lowest hanging fruit to get tackled next, to be able to make that so that this is not just a local thing, but it's something that is just the way that care is delivered?
I love this because I love systems and I love saving all of us time and doing it well, right? I think that's what we all care about. So I see right now that there are a lot of individual site work to develop risk models. There's an ability to compare and create a national risk model for many of these time points along our care continuum. And that's often using either a federated model of merging data. And what I've been learning is, since centers are so protective of their own data, you have to merge data in a very safe way. And this is a federated model, allows you to share code for your risk models and not the actual data itself. So it opens up the ability for my center to work with another center and never share our data across platforms. I feel like we need to identify along the entire continuum the key points in which we need to build national risk models that honor the diversity of our patient communities. I think then we need to build a set of recommendations for how we could do better at each of these time points. And then we need to broadcast that as a community.
So thank you, Amy, for your insights and vision on helping us think about how we can support our patients using AI and technology throughout their entire transplant journey. Just I want to share a few takeaways of things that I learned today. I think my takeaways would be that you can't just look at the point at which you're involved in the care. And I think from a lens of a nephrologist, it's really easy to get pigeonholed into thinking, where do I have touch points, and use that as the kind of pain points from a patient's lens. You actually have to go out, engage patients, and understand that their journey starts well before you get involved. And that you need to think about, both from a predictive AI lens and from a digital intervention with generative AI lens, where are all the places where you actually can intervene? Recognizing that the intervention isn't necessarily patient specific, that intervention may get delivered at a community level where you're actually trying to change some of the factors that go into a predictive AI model that you've established may be responsible for some of the disparities that you see. But also that with the generative AI technology, we actually can take things like digital chatbots, voice AI that's conversational, and use it to fill the gaps in our system, not to replace the valuable expertise of our nephrologists, our nurses, and our partners, but actually to fill those gaps so that the social workers are spending the time in the most valuable way that they can. And things that are easy questions to answer for people, we can handhold them in ways that don't kind of bring down the system from a standpoint of just the fact that a lot of systems are at capacity. That's why there's just not as many kidney transplants as there potentially could be, is because of the capacity limits of our national healthcare system. I think there's a parallel here to some of the things that we do in other spaces. I think there was a lot of skepticism that like predicting end of life wouldn't really help with anything. And yet systems that have tried to link that to delivering palliative care seems like an obvious thing, but can improve access to patients. And I think similarly, predictive AI doesn't have to be a dead end to say that we are going to use that to just let people know where the status quo is, and that's what that is. But we can actually use it to challenge and then actually improve the status quo. So I'm really curious what our community thinks about this. Thank you again, Amy, for joining us. I want to point our community to the fact that in addition to this podcast, ASN members can join us online in the ASN Community AI-powered Kidney Care Network. Log on to the ASN website and follow the ASN AI community for regular updates and to join in on our interactive discussion forum. Speaking for both of us, we look forward to receiving feedback on this podcast as we focus on helping the nephrology community stay current and ahead of the AI curve. Thank you.
This podcast should not be used in any medical emergency or for the diagnosis or treatment of any medical condition. If you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment, please consult your doctor or another qualified healthcare professional. Views expressed on this podcast are those of the speakers and not necessarily those of the American Society of Nephrology.